Oh, right.
Good evening and welcome to this meeting of Adult Social Care and Health and Committee. I am Councillor Lucy Nance, Chair of the committee, and I'm going to be chairing tonight's meeting. The event is being live streamed on YouTube, and members of the public and the media are welcome to watch the meetings remotely and listen to the sessions taking place. Now, I'd like to welcome all those in Committee Room 1 and Kensington Town Hall and everyone watching on YouTube. Before we proceed with the meeting, I would ask members of the committee to make sure that your mobile phones are switched off. And I think it would be appropriate for us to start with 72 seconds silence to remember those who lost their lives in the Holy Church. Start with apologies for absence. I know what apologies for absence, but it's in spirit and Stan that might be running late. Does any member have any interest with that?
I work for the
Minutes of the meeting held on the 12th of October 2023. The action tracker and the minutes of the previous meetings have been circulated as the committee agreed to sign the minutes as a correct record. And starting with our first agenda item, dementia services. Dementia is one of the most important social challenges we face in the borough. Tonight we are joined by colleagues from social care, health and the voluntary sector to discuss the borough's dementia care, its priorities and how we can meet them. And I ask everyone to introduce themselves to this committee. Sorry.
First, hi everybody, I'm Lisa Kavanagh. I'm Programme Delivery Manager for Mental Health for Dubai Borough, work for North West London ICB Integrated Care.
Hi, I'm Rachel Loftus. I'm the Head of Joint Commissioning for the ICB Mental Health.
Hello, my name's Luke O'Connor and I'm Team Manager for the KCW Memory Services. I work for CWL.
Hi, my name's Gareth Hall. I'm the Borough Director for the Integrated Commissioning in Kensington Chelsea.
Hi, everyone. I'm Josh Rundle, as it says on the tin, lead member for Health, Social Care and Public Health.
Hi everyone, I'm Angela Spence. I'm the Chief Executive of Kensington and Chelsea Social Council, which is the CBS for the borough.
Hi, I'm Mandy Andrews. I'm the AGK Dementia Advisor.
Thank you all for being here. And can I start by asking Josh and Gareth and then Lisa to give us a 2-minute introduction to them. And then Angela and Mandy to give 2 minutes into that.
Thank you, Chair. So I'd like to introduce our update to the committee on our dementia services or our dementia strategy that the council launched back in 2020. So we're a few years in now, and we thought the committee's asked for an update on how the council is going in terms of our residents who may be facing dementia or dementia health issues. Now, I think we all have someone in our family or someone who we know who has suffered from dementia. And our strategy tries to put in place services that the council can provide those with dementia, and especially in a big city like London, where there are a lot of other instances that many that people may find themselves slightly nervous or apprehensive about, especially if you're suffering from dementia or early onset dementia, etc. So you'll see in the report, especially at 4.9, which is page 19 of the report, some of the top line things that we've done for our residents in relation to actually part of our dementia strategy. And at 4.10 is like the other steps we're looking at as well to ensure that our residents get the best they can be. Of course, as we know, that Dredge launched in 2020, so it was written in 2019, and obviously we did have 2 years of COVID lockdowns and things, but I think we've been pretty good at continuing with particular of those services, especially those residents suffering from dementia as well. But we're happy to take questions, Gareth and I, on council strategy, and of course other colleagues from other bits as well.
I guess just giving a general overview from the perspective of the voluntary and community sector, and I think some organisations in the borough who are delivering some critical services, dementia services, and just to really highlight the important role that the voluntary and community sector played in the borough in delivering those services. I think, and probably Mandy can go into more detail about some of the issues we've seen in terms of over the years in delivering dementia services, ways in which we think can improve partnership working across the voluntary sector and adult social care and housing, for example. So I think Mandy can explain a little bit more about that. But I think having gone through the strategy, one of the things that did jump out at me particularly was around recognising that there is a higher than average proportion of within certain ethnic communities that do suffer from dementia, that do have dementia. I just didn't get a sense from that in terms of the impact of the report on specific ethnic communities, and I would like to probably see more of that in terms of going forward in relation to a new strategy, just to recognise particularly what has been done in terms of access to those services and take up those services from people from certain communities. The other thing is around wanting to see more in the way of earlier intervention. I think a lot of it focuses on supporting people with dementia, and I think the strategy, I think the ambition was how can we move to much more earlier intervention, and I think going forward probably like to see more around what we could do working together to properly look at the younger age group who, I think we know that dementia is something where it's beginning to impact on younger age groups. I think probably what could we do more together around that. And my final point was around the role of the voluntary community sector and where the future sits with the funding in terms of longer term funding for the sector, so that state services can be provided in a much more stable way over the next few years. So just want to see more of the plan around what that would mean for the existing services or for new services that the voluntary sector can provide.
Okay, Age UK. So we offer quite a few dementia services. First port of call is usually me, so the dementia advisor. I see people who are being diagnosed through the memory service or GP, My Care My Way, and I will visit them at home usually, so we get a good overview of how people are living. We offer a one-to-one service, so people will be referred to for a support worker to work with them one-to-one. We are exercise at home or walking support. We've got a respite service, so people can have a rest. That's 4 hours a week, up to 4 hours a week. That's really valuable. We've got our activities and events, which are for regular members, but we do really try and have people with dementia at those activities and events as well. We're really aware of sort of segregating people into groups just for dementia. So I run a memory cafe in the north and in the south of the borough. People come there with their family members or their carers. And we've got some new, these were all in place when we did the dementia plan last time. But since then, we've kind of built on that, and we've got a maintenance cognitive therapy group that we've funded from outside sources. That we've started that's really successful at the moment, and we're looking for future funding for that. We've done partnerships with the Saatchi Gallery. We're on our second 12-week programme with them, which is a mixed group of people with dementia and regular members. And we've just started a choir, which is an intergenerational choir. So we've got younger teenagers from school who are joining in that choir, regular members as well, and people with dementia. That's been quite successful in attracting younger people with dementia, because the problem with younger people with dementia is they don't want to really go to older people's groups. They want to carry on their life as they've known it. So that's been really successful so far. So yeah, we've done quite a few things in the dementia plan. I think we've kind of covered quite a lot, and we've added to, as Angela said, we can see some gaps with the housing. We have got extra care in the borough, which is really great, but we do need more. But I saw that building some more of that would be fantastic. I think getting people into extra care earlier is really important as well, instead of when there's a crisis and we're reacting there and then, instead of some future planning going on. We could work closer, I think, with social services, Age UK in general, so we could work more in partnership. Again, not just sort of speaking to duty social workers, maybe having someone assigned to a certain team. We could work with some more. So there are things that I think would go in the dementia plan.
And now Lisa, do you want to take copies of that? I think I'm going to say so dementia is one of the priorities of the Borough Bank Partnership. And really, we've got a dementia test and finish group, and that's really focused on three things, which is getting people more people getting diagnosed, to ensure that that people diagnosed get their health checks and get access to diagnostic support. We want to get more people diagnosed quicker, so looking at how we can reduce the waiting times for diagnosis, and we want to have a kind of integrated post-diagnostic support offer. So we commission a number of the voluntary sector organisations, including Age UK, which do a fantastic service. And those contracts we are finishing, and we've got a business case going through to the ICB to have continuing funding for that post-diagnostic support offer, and how we kind of integrate it to make sure that it's streamlined and it's really integrated into the memory assessment services and the community as a whole.
Thank you very much. And I just want to also thank Angela and Mandy and their colleagues who conducted a very good briefing the other day for the committee, which was really helpful in terms of understanding the wider work that you're doing. I think the best way for us to work through this in terms of a question is to start is to look through the 4 priorities for the dementia plan in turn. So starting with priority 1, if we're going to just let members have any questions, that is raising awareness of dementia and the ways to prevent it. So anyone want to start?
Thank you very much, Liz. Thank you for the document, which was very colourful, very informative. I guess in our borough, particularly in the ward I represent, we have a lot of people who never in their life have come into contact with services. They pay their council tax, they get their parking permit, but they've never connected with services before. How easy are we making it for those people through awareness, through the sort of pathway that they get in? Because A, they're probably apprehensive about connecting with services, and B, they don't necessarily know how to do it. And with dementia, we know there's always a resistance sometimes. to actually admit that there is an issue and I need help. And if you've never called for help before from the government in any form, local or national, you're often reluctant to do that. Any thoughts?
And just so we don't have a super long, if we can try and keep answers.
I think one of the things to start off with is about stigma and about people feeling confident to want to go to their GP and I think there's a lot of fear that that what does a dementia diagnosis mean? That that's the end of it. Well, actually, nowadays there are medications which help them, and there's lots of things which can be done to help improve the quality of people's lives. I think that issue about stigma and people coming forward to their GP, I think once people can make that first step to go to the GP, to make sure that the pathway into services and to perceive a diagnosis is as smooth as possible. And I think there's some things that we can do about that in terms of making the pathway between My Care My Way and the memory assessment service possibly easier to navigate. And there's things that we can do about trying to work about people getting scans earlier, which is really important so that they can get diagnosis earlier. But I think right at the start of the pathway is about that, how we address sometimes people's fear about coming forward. And that's, I think, the work about having dementia-friendly communities is really important in that arena. So that people's fear and apprehensive about coming forward is you can do something to relieve that.
Then finding now that the earlier you diagnose a lot of things, the earlier you diagnose it, you get then the easier it is to start the treatment and start the treatment early.
Exactly. And my understanding is as a medical or I should have more details is that the earliest you start the medication, then actually it can really make a difference in terms of the progression of the illness.
Yeah, so I guess it's the National Dementia Strategy was the aim to early diagnosis, and I've been working with memory services in the borough for roughly 10 years now, and I have noticed that stigma has reduced over that time, that the messaging is getting out, and people are coming forward and wanting a diagnosis. But going forward, the aim is the early diagnosis, early intervention, having sort of education and planning in place, so there's better pathways once the diagnosis is made. And there are better medications coming on as well, that from what we're using, that will benefit from early diagnosis as well.
It's particularly having roles like dementia advisor, so that people know that that's a go-to should they need help, and they might not need help when they're initially diagnosed because they might be resistant to that, but actually knowing that there's a main person to go to whenever they need it throughout their dementia journey and helping them access whatever is available in the community.
We do try and be quite visible in the community. I'll go out, I've been in this library here and done like a pop-in session all afternoon so people can just pop in. That goes on social media and then people just in the library just coming up to talk to you. I visit community groups, women's groups, men's groups, and do a dementia awareness talk. So we are quite, I'll go to other groups, other activities and events, and I'll go with all my bits of paper and chat to people. So we try and sort of get out there visibly as well, so people can talk to us, even if they don't have dementia or they don't know anyone, they still can chat about it.
Josh.
Oh, thank you, Chair. No, that's a really good question from Councillor Hargreaves, and I think what the council can do. I mean, I think we all agree that the first point of call from anyone who maybe have dementia or think they have dementia is not necessarily approach the council for that, but what we can do through our services is through the services commission we have contracted, or through our partners, for example, our community champions, which are a group of volunteer residents who go out in the community and help their community as best they can, signposting people to ensure that they can get the right help initially and early, as you rightly say, and how we can then support that wraparound service from that as well. And as I said, commissioning services in order to help them with that, I think, is a really important step. And you raise a good point as well about people not usually having services provided by the council, because the vast majority of our council budget is either adult social care or children's services, that many people will not use that service. So it's always challenging for them to come into that service when they don't know who provide it. So there's always that kind of element to try and build up that confidence, build up that trust, and to say that, yes, you can rely on us or our commission partners, our voluntary sector partners as well, to really help you, because they're not alone, and their services are available for us to help them as best we can.
Thank you. I was just going to ask something coming on from Jared's just said, which I think a lot of what we've just spoken about is going to be our way of communicating with people and reaching. And we've already spoken about sort of 50 to 60 age gap where younger people are going to dementia. So how do we communicate with people so that this prevention? I know we can be going to events and handing out flyers, but even as a council, are there ways of reaching people who might not even want to engage in this topic, because to them it is daunting to even want to sort of really understand what they could be looking for in terms of symptoms? So how we sort of destigmatise that and reach people in the right way?
I think the key, as a council, the key ways for us is about building on when you referred to around dementia-friendly communities, and for our staff in terms of our customer experience, however people engage with the council, is part of the dementia-friendly communities, the dementia-friendly training for staff, and it's, I think, probably fair to say we've had peaks and troughs in terms of the number of staff that have been able to participate in that training. But actually, if there's one thing the pandemic did, it really kind of brought the importance and need for that to start really for people. So as part of our online training suite, particularly when you start, but then kind of regular ways that making sure that whatever that contact with the council is, as far as possible, staff are trained to kind of recognise how they might work with somebody who has dementia or might indicate that it's something that they want to talk about, and their family are aware of how to do that. The other point I think is, Councillor Renner's point is some of our commission services, and particularly for this kind of early stage where then they might not be the specific services that are commissioned predominantly for the older age groups, but some of our public health services that commissioned particularly around the healthy lifestyles and well-being that builds on the point about community champions, but also our weight management, physical activity and general health and lifestyle services are being recommissioned as we speak this year, and we'll have additional investment in pathways for particular groups. And that will include residents with mental health pathways, residents with learning disabilities, but also older people on that diagnosis.
Can I just add to this as well? Because I think, the role that the DCS service that we've commissioned also plays a part here. So we've got a number of organisations who actually engage with certain institutions across our boroughs, like the V&A, to make dementia friendly, dementia accessible. They actually work with a lot of artists. So I mentioned the V&A, but there's the music, there's Wigan Hall, etc. They work with other artists and they train them in working with dementia, so they're actually volunteers, and actually that's around sort of spreading the word and actually, picking up people. So people going to these organisations, but being signposted to maybe to somebody's community, etc. And I think, that's equally, really, really powerful in terms of being able to make our community more dementia friendly. I think that's something that's really quite key. It's using the assets that we've got locally, which we've got, but it's tapping into them.
I'm going to move on to other questions just because we're going to have to focus. We're going through all the priorities. It's going to take a while.
I guess just moving on to priority 2, and it links into early intervention in terms of access. I'm just thinking about the fact that 25% of people with dementia in the community don't have a formal diagnosis. And what do we know about that 25% in terms of demographics and background? And then the other question, I guess, was just looking at I'm afraid I think it goes to a point where this section here just about the wait times, because one of the priorities is about bringing the waiting time down to 6 weeks. and at the moment it's 21 weeks, which is higher than Westminster say. So I was just wondering what additional support or resources or is required to bring that down to 6 weeks. Do we know what the issues are? And also the so that's two questions already, but it just the question about the sorry, go ahead with those two linked ones.
Start with wait time, if that's okay. So I think one, we know that it's expensive, and we know that it's a priority to bring that down. I think we've got more work to do, definitely in that area, particularly around understanding some of the data, and I don't think we're quite there yet. So we've got a couple of pathways in Kensington and Chelsea in particular that we want to look at, we want to focus on. One of them is on a reassessment pathway, but also the other one is the My Care My Way, which is our integrated primary care service that we want to look at. So we want to look at that and look at where the particular pinch points are. We're also doing a bit of work, obviously, AWL are doing a wider piece of work looking at what that sort of demand is. Look, I think it's fair to say you noticed a huge increase, haven't you, in demand for the amount of that you've had.
Yes, particularly over the last 18 months, we've had probably 50% increase in referrals. And we're still trying to get to the bottom of why that is. Post-pandemic, I think there's a fallout from that as well. We were sort of part of that. We were put on hiatus and redeployed, so there was a build-up in the system as a part of that. But there is, we haven't had any further resourcing this to deliver that. So we have quite a complicated pathway in some ways, don't we? So we're working quite well together to try and smooth that out and bring the wait times down. But there are issues around the quality of referrals that we're getting as well. We're trying to work with our primary care colleagues to sort of look at why, as you may be able to see, there's quite a high non-acceptance rate in some section with people already having a diagnosis of dementia, not understanding what memory service actually does. Other factors, deliriums, psychological, that all come to play when someone's referring to the memory service that aren't necessarily for our service.
Is that work that needs to be done in upstream with GPs? Or
yes, that's the plan. Plan is to do some targeted work around sort of criteria, actually what the referral pathways are, and actually to have that engagement. So that's going to be possible.
Yeah. Because it's quite a high number that are being declined, as well as being an extremely high waiting list. So those two things probably
they go hand in hand, and also the impact that has on memory assessment in terms of triaging the referrals, etc. Could be freeing them up to be doing that sort of clinical assessment. So that's sort of the direction of travel in terms of doing a bit of a primary care roadshow, shall we say, in terms of going around the PCMs and having that engagement.
And as any of the boroughs who have got it down to 6 weeks, doesn't.
No, that's very rare nationally. Even across London. I'm part of the memory service London Forum. I'm having a meeting tomorrow with them. We look at all the memory services across the whole of London and sort of compare and contrast practices. It's quite rare even across London. It's a very difficult target given the sort of the scanning, all the other factors that come into place. It's quite a complex thing to do, to come up with a diagnostic test. You have to rule certain things out. It's a bit of triangulation. So it's very complicated. It's not just one test and that's it. So yeah, a lot of things come into play.
And it just before we move on to other questions, that sort of percentage of undiagnosed, is that similar in other boroughs in London?
It varies. It varies quite dramatically across. I think we sit about between sort of somewhere in median.
And do we know much about that group? Just since following on to what you were saying earlier.
You mean
or are they an unknown?
I think they are an unknown at the moment, but I think there is some work in the future we can do about using the population health approach. So we can do more data analysis and look at where possibly where there's different levels of diagnosis within different communities, and then try and focus on communities that we have the prevalence isn't there, so we can do a bit more targeted work. And I think that's also about understanding our data better. I think we really, if we can understand our data better, that will help us kind of identify the people we don't know and be able to do more set outreach to those communities and more kind of engagement with them.
I do actually see people who don't have a diagnosis sometimes, or who refuse to have a diagnosis. So we will still work with them, and they know they have a memory problem, but they just don't want to know. And that is a number of people. They would rather just not know. But I still work with people, they work with us without knowing.
Portia and then Sam.
Thank you for coming. Very interesting report. With all the priorities listed from 1 to 4, on page 74, I cannot see how we're going to meet the target because the diagnostic is at 66.7 nationally. And we've only managed to achieve 62.2. How are we going to be able to achieve it nationally, considering we've got 92 people in PNC financial year? I mean, is there a possibility that we're understaffed? Do we have the resources to do so? Are people getting trained? Are they enjoying their job? So these are all the questions that we need to ask. Why are we under target? Are we understaffed? Have we got the resources? Workers are enjoying their jobs. Are they getting the support that they need? How often do they get trained?
I think there's a couple of things there. So one of them is around the referral pathway. So we've done a bit of work where we think there's an opportunity that some people have been diagnosed but are not actually on what we call the quality outcomes framework, which is the register, which tells us how many people have actually got that diagnosis. So we think that's a bit of a coding issue, and we think there's a piece of work that we can do with our primary care colleagues in regards to able to look at their patient list basically and who has actually been diagnosed to make sure that they're coded correctly. But this is not just a numbers game, is it? This is about making sure that people have got access, they're diagnosed, people have access to the right care support that they need, or the right medication, etc. That's what that is. I think there's that's sort of a key piece of work that we need to be doing. And I think again, it's around some of the things that we've been talking about, are we reaching out to the right communities? How do we understand that demographic, that is the prevalence bit, shall I say? You know, those people who are not diagnosed, are we doing enough to reach out to those people? And I think that's something that I think we spoke about in terms of looking at that population a little bit more, and how to take a population health approach. And again, looking at what that actual referral pathway is, where are their challenges? How do we get people diagnosed quicker? Because the routes for diagnosis at the moment are via our memory assessment service. So most people will come through the front door of their GP, and then from their GP will then have other things ruled out, and they'll be referred on to the memory assessment service or my care work. And again, you know, if we're getting these high level numbers of inappropriate referral, that's taking up a lot of clinical time in terms of triage and issues. Does that mean that people get diagnosed and get so there's a multitude of things I think that we can do.
Yeah, and just that I think that we're looking at 92 people. We had 92 people diagnosed, then we would be meeting that at 66.7%. So in one sense, some of those 92 people are what Lisa was saying are properly diagnosed but aren't on the register, therefore don't count. So we've been doing that piece of work to tidy up the register to make sure they're on the register and therefore they get their checks and everything. And then the other piece of work is how we reach out to this group of 80 kind of people. How do we find those people to enable them to have the diagnosis? Andrew, thank you.
Yeah, no, I was just going to say, I completely agree. You're going to, I think it will be really important to have a targeted approach with certain communities, and particularly because there'll be a cultural element at play with this as well. You know, the tendency to want to look after your parents at home and, you know, kind of do it between the family, recognizing that that's probably the first thing that they would want to do before they then seek help. So there is something about how you create the conditions for education and training and understanding on what's out there and what's available, but really important to work with those community groups where we'll need that targeted approach and just to understand what those cultural barriers are. I'm sure you know and understand that, but I just feel, you know, as you say, there'll be people out there, families who are looking after parents, particularly where they just haven't reached out because they haven't got to the stage yet where they feel they need to do that. They're trying to do it at home for themselves. I think, yeah, I think the more we have those conversations, the more we.
And the language we use with people, I
Yes,
think,
it's
where
very
it
good.
is. Sorry.
Could you, I asked a question, I says, are we understaffed? How well do the staff enjoy their job? Because it's very important, when you go out into a population, it's a very difficult job engaging with local residents who are experiencing certain illnesses. Now, for us to reach our target, we understaffed, we've got the capacity. Do they enjoy their job? These are the questions I want to ask because staff do get burnt out. Do they have the capacity to carry out their job? HUK, they're very visible in North Kensington, as I know. Understaffed. Are they understaffed? Have we got the capacity? Undiagnosed, how are we going to reach those? Is there a roadmap to reaching these people? We know, okay, we have to do more community engagement. We know we have to make ourselves visible. It's winter now. How are we going to do so? Is it going to be a first mandatory questionnaire through the GP surgery to find out? Are we going to liaise with their family members? So there has to be a roadmap. We have to follow that line in order for us to actually monitor and to see if we're getting more people.
I think that's something about going back to dementia friends training,
Mhm.
because people come into contact with all different services, don't they? So it may be, you know, they go to their library or they go to another council services. And if we've got people who are trained as dementia friends, then they will be able to kind of have more understanding and be able to possibly support people in terms of just maybe having a sense of thinking that maybe they you know they might go to their GP. I suppose it's getting people to their GP. When they get to their GP, then we can kind of like you can work with them, but it's then taking that first step. And I think also understanding that actually dementia is treatable. I still think there is a conception that if you have a diagnosis of dementia, there's nothing that can be done about it. Yeah. But actually, there is things that can be done about it, and actually, that message I don't think has got through. And I think that's a big kind of thing really. Actually saying, you know, it's a positive thing about getting a diagnosis and actually not just access to services, it's access to medication, which actually slows down the disease and enables people to have a quality of life for longer.
I'm going to take it to a UK person.
Yes, but I still haven't got my question. I think you go ahead.
Is that to me as well?
No, I understand your perspective. What I want to see, we've got priorities set in front of us, and I just want to see it visibly. How are we going to get from A to B? And if I cannot see that, there's always going to be questions coming. I know they've got some good ideas, you know, and good things to go forward, but I want to know that this is going to be done. And I wanted to know, are we understaffed? Do we have capacity?
So, you know, this is it. Yeah. I mean, sure, we're not understaffed, but we could always do. We could always support.
Thank you.
Yeah, totally, absolutely. More support workers would be amazing, and we would reach more.
I think going off what you said actually in terms of this whole paper and where you want it to be going. It's sort of understanding actually what length of time are you going to start seeing percentage differences in how many people are going to be and this undiagnosed proportion of this borough and people who are, again, with the confident who are super reluctant to come forward, how we can change that around and what timeline are we looking to?
Well, it's the pieces of work about like improving the time to getting a diagnosis. That's something about doing practical pieces of work about improving referrals, because as the data shows, about 40% of referrals are declined. If people are not having to screen inappropriate referrals, then they will have more time to do actually the diagnosis. So I think making our system much more efficient in those kind of ways will actually mean that actually the memory service will be able to do more with the resources that it has as well. But I think we all know that, you know, more resources it's we all want more resources.
Sorry.
If I may, I just do a point on data, which I'm happy for people to disagree with. It's something I was told as an board of the university, which is on healthcare, and a professor of public health said that you can easily misdirect yourself with data, particularly if you're comparing non-homogeneous populations. So if we compare ourselves with Tyneside or Devon or something like that, and we say it's very well to set a target, but they told me that percentages don't move as much as people think. There are specific things. If there's a fault which you can correct, either if it's staff or training or something else, but some of the percentages are very much a reflection of your build-up population. And even I don't want to delve into it now, because obviously you can talk about everything. But even in quite a compact health region, you can have differences in rates reflecting different populations in different areas. So I'm not asking for an answer on it. I'm just throwing it in there, unless it's completely wrong. That if we're 4% away from something, but it's a handful of people that may reflect the population and the way that population likes to interact with the health service, shouldn't necessarily beat ourselves up about it, because it could be that we're just reflecting our populations. So I do have a small comment on what could fit into priority 1 or priority 3, and it may be, again, it's just throwing an idea of something I saw out there, I think, just in case people haven't seen it. Creating a community that's dementia friendly. I saw an example, and it was in Japan, a place that can be more friendly in a way than some other countries, of a restaurant which is to serve young people, but is served by dementia patients. And the interaction, I've seen some films of it, is endearing, because it's patients who realise that they're interacting, and that's their sort of very good fun to do. And for customers who are going in there, they're getting a new experience rather than saying, I want this, and it's slammed down in front of them. They're interacting in a different way. I'm not saying there's an easy place that this can be done in Kensington and Chelsea, but when looking at different ways, we do have some sort of community hubs or restaurants, and I don't know how it would be organised, but it would be a pity if we didn't know if there's an example of this operating in the UK.
I think there's one in Newcastle. I'm sure I read it the other day, and I always remember that looking at it. But that would be a brilliant idea. That would be so brilliant.
Very good. With that, Andrew, your comment. Nothing to add.
I've got a lot of other comments, but I'm watching the clock, so.
No, you were going to check it to, sorry, just before I go to Jared. You sure?
We're just picking up on, so page 62 and 63. And it's like all the reports out of this book. They're all very positive reports, but there's no real detail. So if you just took priority 3, embedding dementia design across all council services. Lovely statement. Nobody can disagree with it. What does it mean? How's it going to happen? What's the route for it to happen? What does dementia design across? What does dementia design mean? What is all services? Working with local public, private and third sector organisations to create a holistic dementia friendly plan. Lovely, can't disagree with it. What's it mean? What work are we doing with the churches, for example? What work are we doing with the Rotary Club? What work are we doing? Where's the grittiness in it? And tell me if I'm being unfair, but
I think, no, you're not, Gerard, and I think I'll let Gareth comment on specific points or other members here as well. But I think that's always the issue with the strategy, because the strategy sets the overall vision. And this is the strategy. This is not the operational element. This is not the KPI matching it. This is not the kind of the action plan, let's say. This is the overall strategy. And I think in relation to embedding dementia services across all the council.
I'm going to use
as an example, yeah. So that is, as Gareth said, doing our dementia training. I mean, I've done dementia training myself. Many councillors did in the previous council, that is 2018 to 2022. But I think we should potentially do that again for current members. That maybe not.
We're doing it for business, so we're doing it for whoever.
On that point around the wider community, just kind of council staff being trained or staff being entered in the voluntary sector. Pre-pandemic, through the local Dementia Action Alliance and the voluntary sector organisations, and that was being rolled out a lot more broadly. If I'm honest, I think that's taken a bit of a dip since then, in terms of kind of resource capacity to that, and people shifting to different channels of engagement during that period, which did work. But as we've come away from that period, I think there is a case for us to really, and to pick up Portia's point about kind of timeline increase for work, so that we can continue to evidence what was originally planned around businesses, organisations across the community having access to that training. There are other points in priority 3 and some of those others where, without having it all in detail here, there are kind of specific elements happening, particularly around the use of assistive technology and technology-enabled care, where that's what people want, or where it's right for the others for it. And examples both here and other places around the country where that's proved particularly effective for people being able to remain independent at home, and also crucially to provide security carers and family carers for people and to give them the assurance you have. The other point was to pick up around embedding dementia design across all council services. I think specifically in relation to some of our extra care services, which were mentioned previously, and future residential care services. There are specific guidelines around dementia friendly design for buildings, and that make them more accessible for people, and don't cause undue alarm. One area where that will particularly be a factor is with the extra care facilities that we don't think a lot's road. There'll be a dementia design element to that, but this will be a good example.
And the Dementia Action Alliance is still ongoing, but it hasn't been as active in the last year. And we did do dementia friends training with certain organisations. We went into the fire service and we did North Kensington and Chelsea fire service. We did sessions there, and we were aiming to do them in various businesses. And the council was involved, but the last 3 years it has dipped.
Good challenge.
Gerard, do you have?
The Dementia Action Service is the dementia sort of action service at the moment.
But it's a collection of businesses and people who are interested. So it's kind of a voluntary, and people have got to have time to go to it. It's got to be organised by someone. It's got to have a venue arranged. So people they try their best, but everyone's busy. It was easier when the council were involved. I think Andrew was involved, and so we got rooms easier, and we got other people joining. But again, it's really hard to sustain when it's voluntary, really.
I'm just going to ask a question on priority 4, which is giving unpaid carers field support. And just to hear whether what we are doing for unpaid carers is, I think, quite often they are very as much as those that are looking after, and sort of their access to counselling or sort of support systems, and what that's, and how quick that process is, and how much access they do have to it would be good for us to understand.
Yeah, I think the fundamental in terms of our role as a council is in terms of assessment and allowance and support for carers. The role in the teams here, actually in the public sector teams too, is once carers are identified and referred into the service, everybody has a right to an assessment as a carer, and a support package can be put in place from where that's appropriate, and that can include the carers allowance, which comes through from DWP. But on top of that, we also commission specific carers support services, primarily through local organisations, including OGK, but also the Carers Network, which provides all the services, provide information and advice to groups, and run support groups for carers of people who are living with dementia.
So yeah, we have up to 4 hours a week funded, council funding respite, but it's not ongoing. We can have it limited to around 6 months per person because it's so limited. But again, you can be referred again. So we have had people who've, had it a couple of times. The respite is really needed, especially towards palliative care and end of life. When people are at the end of their journey with dementia, there is nothing really much out there for people, and they're usually looked after by a partner who's elderly as well, with their own medical problems. And so you often have, not often, I have clients who both the wife and the husband both have dementia, and is being looked after at home by an adult child who lives in another borough or another part of the country. So the respite, is really important and needed.
Maybe it was about the previous point, but just in relation to that, what do you know kind of what proportion of the people who are being diagnosed with dementia go on to automatically require carers assessment for their what proportion go on to need a carers assessment, or does that happen just automatically? The referral is made.
Commonly, that will happen automatically. So if somebody is referred to social care for an assessment, and the social worker at the time will undertake an assessment of the care or make sure that there's information advice on the phone.
Do you need the formal diagnosis?
And then somebody comes in with badly or prefer themselves.
And are there sort of special provisions for people who are single, or isolated?
Single care.
No, so single who are the service user themselves, not caring.
So there are advocacy services for people who might be on their own and provide support for them in working and engaging with us to make sure that they're getting the right service for us. But the other services that we've been talking about commissioned from the voluntary sector, including OGK and the Carers Network, are there to support.
We do have carer support groups as well. I forgot to mention that when I spoke about those. So we have a carer support who meets up and support each other. So we have 2 groups doing that as well.
I think we should maybe start moving on, but any further questions from the committee?
I just wanted to pick up one point around hospital discharge, and I haven't seen it in here. I might have missed it, but in terms of referral pathways for people coming out of hospital, where they may not have the support at home, and is that recognised as part of the plan in terms of how we support people coming out of hospital with dementia?
If they haven't gone into hospital with a diagnosis of dementia, but are coming out and need support needs, then that would form part of any kind of discharge process plan. Whether that's an interim arrangement, whether that's a package of support, or reopening with something at home that then leads on to a personal assessment.
So there is a pathway.
I was just going to ask you if these are options. How do we go out being a more dementia friendly borough? And what can we do? I mean, I know Sam just came up with one very interesting option, which might not necessarily happen anytime soon, but what can we be doing that's sort of different and leading the way? And I mean, something for you.
Yeah, no, so we obviously want RBKC to be the best place for people to live in, and that includes obviously being the most dementia friendly borough we possibly can. But I think ideas like Councillor Macover has made has been really, really good. See what we can do. As I mentioned, we've got the 65 new care homes coming in Lots Road, which are going to make a significant impact on residents as well, especially in that in Councillor Hargreaves ward. That will make a real great impact on that. But also, it's also about the public realm as well. I don't know, when we've had the discussions, especially on the dementia friendly training, that members should all go, and I encourage you to making sure that the public realm can work for people with dementia or suffering from dementia as well. So that's obviously trying to encourage, moving things on like e-bikes and stuff, but also making sure that our roads are best they possibly can be as well, with different kinds of colours, different kinds of sections that people can realise that when they are walking, they have confidence to do that as well. So I think it's a really big holistic approach. So it's not just one person resolution, but working with all departments of the council and with obviously great organisations like Social Council and HUK, and obviously with our NHS partners as well. We need a coordinated thing, and that's what the strategy tries to do. But of course, there's always more to do, and any ideas that people have, I think, we greatly encourage.
Any further comments from me? I decide before we.
It's just a thought. So the page which talks about BCS post-diagnostic support, contracts coming to an end in March 2024, and assuming that we've got a business case for funding beyond then, what happens if we don't get that funding in for the voluntary and community sector for those who support that current services to post-diagnostic support, and what's the plan for the alternative? And should one would hope that there would be, but is there thinking about what would happen if there isn't? And I also think that has a knock-on effect anyway, because by the time we get to January of next year, these organisations will inevitably start having to think about the future of that service. There's no decision around the future funding.
I think we can both said we're trying our best and in terms of business case going in and really understanding how great our services are and how they benefit the borough, and actually part of the North West London dementia strategy is about having a post-diagnostic support offer. So we need a post-diagnostic support offer. So I find it very difficult to imagine that they could say you're not going to have any post-diagnostic support. But I do take your point in terms of the timing and ensuring that we can get a decision on the business case.
Well, thank you.
Well, thank you all for coming. And just before we close, any Ms. members have any recommendations?
All right, then.
Thank you very much. I think we just we look forward to seeing figures hopefully getting better over the next year, and
Sorry, Chair. I just wanted to touch on something Angela said earlier about cultural sensitive engagement. I'm quite aware that there's a lot of thing, I would need to say, use that word, but Black African Caribbean people who are undiagnosed. And as a duty of care for safeguarding, I think it would be in our best interest to maybe put out, or do we have to ask for permission to do so? What do you suggest?
Are you talking about in terms of data, understanding it better, or?
No, in terms of diagnosis. So if we are aware of a resident who are suffering from dementia, but they haven't actually, been diagnosed, you have to put it to adults in social care.
Try and encourage them to go to their GP.
So it's just the GP. So the GP will be the first point of call.
Yeah.
Okay. Thank you.
Thank you very much, and thank you for all your contributions. Great. Moving on to our next agenda item, which is safeguarding adult executive board and the report for 2022. Eileen Buckton, Chair of the Safeguarding Adults Executive Board, presents the report, and I'm joined by Louise Butler and
Thank you, Chair. And now I'll introduce the report and Aileen and Louise can come in on specifics. So this is the annual report which must be done statutorily for the Safeguarding Adults Executive Board, and Aileen is the independent chair for the Borough that is Kensington, Chelsea, Westminster, as we know. And the Adult Safeguarding Board has to bring together all agencies, so that all agencies across both councils, but also other external agencies as well, such as Metropolitan Police and others as well, that can contribute to what we are going to do. And of course, part of the us, obviously as a member, as the council of the executive board, is to ensure that obviously keep residents safe, ensure that we're learning, listening, and to have the best place that we can possibly live in with based on Aileen's recommendations and chairing of the board itself. But yeah, as I said, this is the annual report, and happy to take questions.
I think you're done.
Perhaps if I could just make a few comments, and thank you very much for the opportunity to present the report to you, and very much want to welcome your challenging questions. We have four priorities, which Councillor Reynolds just outlined, that kind of govern the way in which we operate, and those are set out in our 3-year plan, and that's about supporting communities to keep themselves safe. It's about us working to make sure that safeguarding is personal, and that means that those people who have been subjected to harm or neglect of some kind, that we work with them in a way that they actually feel that they have been listened to, and that they're kind of, they set outcomes that they want to see for themselves as part of that process. That's one of our priorities. A huge priority in terms of leading and listening and learning. And our fourth priority is about quality and performance. So we have those four overriding principles, and each year we set ourselves a set of kind of targets and objectives to work towards during the year. And we do that by having an annual audit. We will be coming up for our audit for the year that we're currently in February, March. And we actually do a kind of challenge assessment for ourselves, all the member the members of the partnership, where we look at what's gone well, what hasn't gone well, what are the kind of new issues that have arisen during the year, what do we think we need to continue, are we satisfied with the outcomes that we set for ourselves, and we also ask others as well, that we actually do some kind of consultation that feeds into the plan. And so that's what we set for this year, and this is for the year that we're looking at, and this is the account of what we achieved. In particular, I just want to say that our priority during the year was really our first priority, about helping communities to make themselves safe. And it was something that I think became a priority because of the pandemic, in particular, of people being very kind of hidden away, and us wanting, as people came out into their communities again, to take the opportunity to work with different communities, and particularly communities that we hadn't really engaged with before and we hadn't heard from, to try and get across a message of what is safeguarding. It's not an everyday term that everybody's familiar with. It's very, and it operates very differently in different kind of cultures, and people's understanding of what harm and neglect is. And it had been very important to us to really kind of work with the local kind of communities in the two boroughs to get that message across about what it is, what does feeling safe feel like for many kind of different communities that you represent. And so quite a lot of the report looks at the work that we've done in terms of developing relationships with safeguarding ambassadors. So having people in the community who will talk to groups that they're part of, who will talk to neighbours, who will actually take forward the kind of message of safeguarding. We've also worked on the Stay Safe project, which is working with those kind of communities where we need to kind of think about delivering in different languages. And we've actually done that with quite a high number of kind of communities and have been very supportive in that work. We have also done a lot of work with voluntary sector organisations and had a kind of community engagement day with them, and they kind of came back with what their ideas are. So what you will see in the report, I hope, is a kind of blend of what individual organisations have done themselves and what they've tried to address in terms of their kind of priorities for the year as part of our overall work as a board, and what we've done together as a board, and some of the work that we've undertaken. One of the things that I'm hoping that the kind of we're trying to put in some stories of what the safeguarding ambassadors were saying, so that we can really kind of reflect the importance of that. Within the report as well, we talk about making safeguarding personal. We're very pleased that when people are subjected to harm and neglect, they feel, well, what can come out of this, really? And we have been able to work with families. They have lost somebody who has died, work with families who now are working with us to put forward a kind of message about safeguarding, what they have got from the kind of process that we have undertaken. And we always ask people that if we're working with them, what is it that would actually in some way help you to feel safer given what has happened? And we do have a high percentage of people who positively report back to us on that. And we're very pleased with that development. We have to put in our annual report the safeguarding reviews that we've undertaken, and we have done that as part of this. The important part of the reviews, they're not about blaming people. We have to undertake the reviews when something has gone wrong or has nearly gone, usually when it hasn't. And we want to learn as agencies working together about how we can train staff, put new kind of practices, new policies into place that will ensure that those things don't happen again. So you will see that learning in there, and that will always be a focus for us year on year, but you'll see what we did in this particular year. And then there is a kind of section as well in the report where we've worked hard now to get significantly more data than we had, to look at diversity in terms of the data that we're collecting. It is a priority in this current year as well. It's something that we really want to look on and focus more, and using our data to make sure that there are quality services across the board. So I will stop there, Chair, but I'm very happy to.
Thank you very much, and I just want to welcome this report. I think it's fantastic. We had a briefing from Professor Jill Mantle earlier this week, and I asked her how can we sort of be aspiring to be the best borough, or we should be looking to as to who is getting safeguarding right, and she said you're at the top. So it was fantastic to hear that from her. But obviously we need to always be striving to challenge ourselves, and that's why we're here. But I just wanted to start with going to page 134 and 135, which is the data tables, and just talk specifically around psychological and domestic abuse, which
51 and 52 in the actual report.
yeah. Sorry.
Thank you.
With the graphs on. And just to understand a bit more about this data, specifically the comparative risk of harm alleged over the last 4 years, and why you think we're experiencing higher levels of psychological and domestic abuse.
You might want to say something about the actual data. But I think what I would just say to start with is that that we have, I mean, the numbers aren't hugely significant, but they are significant enough. There is, there is a shift. In some ways, you would expect that because we have more families who are looking after people in their own homes or people in their own homes themselves who are supported by services. So you would expect there to be a rise. But it was one of the things that we feel was a kind of direct result of what people underwent during the pandemic. That I think that there were more kind of pressures and strains on families, and we did see evidence that there was a kind of drop in referrals actually during the pandemic itself. But afterwards, we did see an increase, and certainly residents and communities have told us about people's concern about domestic abuse. In particular, and it's also a picture of Lydia's work as well, about the abuse towards older people, which is part of that domestic abuse. So in a way, it's a kind of shift that we would expect, but it's important that we really kind of grapple with it. Lisa, do you want to say something about the data program?
So it's not a massive increase, it's a very small increase. There's also a very small increase at a London-wide level as well, so it's not just us as standalone. However, we know that RBKC only has 11 care homes, whereas Croydon has many, many more. We've just got to be a little bit careful with looking at the data. But I think that we were sufficiently concerned enough to actually begin to look at this in a bit more detail. And that's exactly what we want to do. And I think we've got to use the word domestic abuse a little bit more loosely in terms of deep diving and understand who's actually abusing who. I'm very interested to have a look at unpaid carers to see the role they play with looking after their loved ones and stresses and how that's actually interpreted. So we're doing quite a lot of work now with community safety in our Advance Against Women and Girls Partnership to actually unpick this in more detail so we can really understand what's happening. We've already made great strides in raising awareness around this. And in fact, if you looked at the online version, I think there's a video that looks at the domestic abuse and raising awareness. It talks of the Angelou Partnership and how the safeguarding ambassadors have been working with them to raise awareness across the patch. So we're already onto it.
Thank you. And just one quick question before I go to my colleagues. On 2022-2023, there's the addition of discriminatory section that was added this year. I just was wondering why it didn't feature in previous years.
That's a really good point. It's a very unreported abuse type. However, when we report on abuse type, we're reporting on the primary abuse, and discriminatory abuse is exactly something we're looking at now. However, we've been working on it with a different name. We might call it hate crime or make crime, but in fact, that's some work which we've been asked to look at a national level as well. And we recently presented a webinar nationally through ADAS on the work we've been doing, which actually links to the Staying Safe project. But it is very underreported. It's not just us here, and we're going to have a drive over this next 12 months and beyond to actually understand again that much more. We don't even have a definition for discriminatory abuse. No one really does. So we're going to be looking at it in a little bit more detail as well.
Sure.
Thank you for your report, lovely, impressive. I just wanted to know what percentage of our clients feel that the representative are representing their views? Do you have the number?
In terms of people who,
Yes, so the people that are in your care, how many of them feel that their representatives are representing their views? Do you measure that or is it something that?
what we have are the outcomes of what people are looking for when we undertake a safeguarding case. So in fact, it wouldn't be everybody that social care will work with, but those people where safeguarding had been identified as an issue. And so we have the percentage of people who felt that what they were seeking was met. And that's of all the cases that we have looked at. So it's a percentage of those. Is that specifically, Councillor? I'm not sure that I'm actually answering your question.
It's sort of similar. I mean, I just wanted to know if they felt like their views were being taken on
Yes.
from their representative,
Yeah,
and what percentage don't feel that their views have been taken on, and what?
So on
How
page
you work.
136.
Yeah.
In terms of outcomes, what the data is telling us is the fact that, today's data is telling us that about 98% of people in RBKC who've had a safeguarding referral feel that their outcomes have been achieved or partially achieved.
Brilliant. And what about the rest? Are there any measures in place to get those to be resolved? Or satisfied the other percent?
2%, yeah,
The 2%.
we try to do it with everybody, but, you know, that we work with, that's, that is always the aim, really.
Thanks, Rochelle. And thank you so much. It's a great report, and I know a little bit about what you do, and I think the examples just really bring to life what the aims of the board are, and you know, just so interesting to read, and it's just such a wide scope of work. And actually, the question I had was really about the board itself, which is probably the driest bit of the report. But could you just bring it to life a little bit for us? And you talk about the links you have with other boards and partnerships and resident groups, and you talk about the local account group, and I can see there's lots of subgroups here. Could you just tell us a bit about your year and how your meetings are and how you engage with these different groups?
Yes, so the board work on reviewing the previous year and setting the kind of priorities for the year, and then work out their kind of programme of work for the year. The statutory partners are the local authority, health and the police, and then we have a number of health provider organisations. So we have a number of trusts who sit on the board. We have the DWP, we have a number of voluntary sector organisations, the probation service, work reserves, the fire brigade. So it's a wide range of partners on the board. And what we always try to do in talking about our programme for the work is to ask why we're going to have a particular item coming to be presented to. So somebody presents a report, somebody might come from Community Safety Partnership and might present a report. The purpose of that is, what can we add in terms of a safeguarding perspective? Because they've done a lot of detailed work, they've got their strategy, they've got their plans of work they're doing. What we can do is to provide a wider membership who would look at that report, who would understand it, and then begin to kind of question, are there some safeguarding concerns here that we could focus on, or that we could kind of help with and support? So it's always about what additional thing can the board add. And we all say to people, if you're presenting anything for the board, please ask us at the end, what is it you would like this board to do for you? So that we don't just sit there and listen. We do listen, but we respond and think, what can we add to it? So the board meets quarterly, but it sets quite a number of kind of priorities under each of our overriding priorities. There's a number of pieces of work that have to be undertaken, which is why we have, and I know it looks complicated, that subgroup structure. And those subgroups are made up of the member agencies of the partnership, and they're chaired and co-chaired across the board, because it's very important that it isn't just the council. The council gives the backbone to supporting the partnership. That is their role. But we really want all of the agencies to play their part, so the partners to play their part. So, you know, so the fire service have been very involved in our community engagement work, not just from the point of view of their own service, but across the board in terms of safeguarding. You know, we have members of the police as well helping in the subgroup. So the subgroups undertake the detailed work and report back to the board, as well as us hearing from other partnerships that might be across any of the agencies, in the council, in health, across the board. And we want to know the individual work that they're doing, so that they are also getting some challenge from the board as well, and some help and support. And then the most important thing as well is that we always like to have the voice of the service user or of the community in part of what we're doing. And sometimes what will happen is the community representatives may not want to sit through a very long board meeting. You know, they're not necessarily the most lively of things sometimes. But they will do a video and make a video and present to us, or we will have an event with them beforehand and talk to them about some issues that are of concern, and that's central. And we also encourage the subgroups to always have a perspective from a service user, sometimes, you know, from a manager of a care home or something, but, you know, to talk about the real nitty-gritty of their work and how safeguarding is impacting upon them. So that's also part of how that would happen in the kind of board meetings. Does that give you enough of a flavor?
It does, thank you. It's really, really helpful.
Yeah, I just had a quick question about some of the figures on, so it's page 58 of the actual report on page 141. It's quite striking that the vast majority of people that have the safeguarding alerts raised, who are referred for the safeguarding, aren't aware that that's happening. It says that the vast majority, less than 27%, are aware that less than 27% of the service users who are being referred for the safeguarding are aware of it. Which that probably is an even smaller number of people who have mental health difficulties as well. And I was just wondering why that is, or how we understand that, and then how that marries up with the figure of 98% being sort of satisfied with the outcomes.
You're absolutely right, Councillor, that when referrals are first made, I mean, sometimes they come from members of the public, you know, who say, I am really worried about the elderly lady who lives next door and for X number of reasons, and you know, so and they don't want it. They don't want to say to their neighbour that they refer, but they're concerned enough that they contact us. So that's just an example. But so it is quite common at the beginning that people don't know that they've been referred. But obviously there then has to be a further analysis of that referral and kind of a contact with the family themselves. And we would want to move quickly towards people very quickly knowing that they have been referred, or the families kind of knowing. I mean, sometimes you do have to be careful about that, because obviously the safety of the person is the most important thing. I mean, that's what we're trying to make sure that harm doesn't come to people. But it is good practice to make sure as early as possible that people do become aware of the referral and that families are engaged with it. And the sooner you can do that, the more chance you have of being part of the 98%. Because once people do know and they're engaged in that process, then we talk to them about, okay, this, you know, we're concerned about X, Y, and Z, and work with them. Sometimes the referrals don't go any further than that. They don't necessarily get taken to another level, and sometimes they do. The 98% is the percentage of those that actually are safeguarding investigation. So really it's about that we should engage people as quickly as possible in knowing that they have been referred, but we would always take the view that their safety is of the utmost importance. And if that means working without telling them to start with, then that would happen. So it is it's a professional sort of judgment call, but it's one that, you know, that we're very kind of aware of.
And is that the majority of cases where it's sort of a safety decision or a clinical judgment that they shouldn't be aware of it?
I'd say that the initial referral may be that people don't know, but the majority of cases that people would know very quickly after that. I think it would be rare that you're in a situation where people don't know, but I'm just saying that sometimes there may be instances where that was the case for a certain period of time. But good practice would be, as soon as it is possible, you talk to the person who has been referred. Yeah, absolutely.
So just to add on there, Aileen, in domestic abuse cases, you wouldn't necessarily tell the person immediately, you'd assess the risk first.
Yeah.
So those are the sort of cases.
And that's
that
the sort
we-
of thing, but.
Thank you for this report, fascinating, and very educated, really. Just wondering what the question is about who sees this report, most organisations have their own safeguarding officers. I'm just thinking of the church, which is in Anglican church, but I don't see them then, for example, give me an example reflecting. So how do all the organisations in a borough like ours that are doing their own thing, every little business or whatever, how does there's a list in here of some, how do all the others, and do they get a copy of this report? Does every council get a copy of this? What happens to it?
We mainly spread the kind of word of the report and of our work through our website. You know, the report is kind of available online, and many of our organisations now do access in those ways.
Our organisations, who do you mean those that are currently working with you, or?
No, in terms of making sure that it goes out to all voluntary sector organisations in the borough, making them aware of the kind of link to the website. We used to produce many more copies of this, but obviously we're trying to do that less. But we do have some kind of paper copies, you know, for people who really don't have access to technology. But most of the organisations that we work with do. And we do make sure that we have a kind of wide distribution. And I think the other thing that's important is trying to make the report accessible so that, you know, a small organisation or a church or whatever can look at it and think, oh, actually, this might be something that would be really, you know, interest to us, or we have got some concerns that we want to raise. I mean, there's a lot of kind of data and analysis and things that we have to cover within it, but we try to make it that it's accessible to people, and it does go to all elected members, and we, you know, very much wanting to sort of encourage members to share it with people that they're working with, because that's a very, you know,
Notwithstanding, that came through as an email with an attachment, probably wouldn't get. Oh, interesting. I must look at that one day. And by the time I said that, the inbox is full of the next lot of reports.
I think we're always conscious about how do we get messages out, because that's why we, you know, have the ambassadors and things. So that's a useful comment, and I take that on board, in fact, about what are some different ways that we might be able to get the message of the report as well as the report itself, get that out. Thank you.
Can I because I think that is really important, actually, because safeguarding is only ever going to be as good as the awareness that people have of the need to do it or how to do it. So that was actually the other question that I had, was what additional support could the council provide, or if it is the council's role, I don't know, or what could be done to kind of help in improve the education and awareness that unless you actually work in healthcare, you might not be aware that you have duties to do this sort of thing, or that this is available if you come across the fact that your neighbour is struggling, or you're concerned that safeguarding alert needs to. You wouldn't know what to do.
Just going off on it's quite well spoken for those. It's just how we can actually be utilising this report, which I think is fantastic, and what Gerald's just said, that it probably in many cases falls on deaf ears and inboxes. And I know we have counsellor training around safeguarding, but I do actually think it should be a compulsory thing, potentially yearly, because safeguarding and the threats that our residents are quite often met with are changing each year, and there are sort of updated areas you go into in terms of sort of financial abuse, and whether there can be more in terms of actually what Mon is saying, and Gerard, residents and councillors come into contact the whole time, and if they're not trained in an environment where they have knowledge of what to be looking out for, they may not even know what could be an issue that they should be flagging, and whether there's more that we can be doing to utilise this report and the training within the council, so that we are ensuring that
particularly, I'm sure officers are going through this training too, but elected members know what they should be looking out for. And I think in terms of this report, particularly the digital one, hearing the stories that you are putting this effort into telling virtually, because I would hate it just to sort of not be utilised in that sense, that it should be, we should be making use of it, and we should.
I mean, we very much welcome that, and talk about it a lot. So I think any kind of thought about how we get those videos looked at, but also for the training, I think is absolutely crucial. And I think you are right about, things do change on an annual basis, really. You know, that there are new concerns, there are new things that you realise that are prevalent, you know, that you want to get a message across. So, if we can get messages out to elected members about, I mean, I know that you have a very full kind of training programme, but it's really important to ask about it.
I'm just thinking about surgeries. I mean, a lot of the people who come to our surgeries, there is a potential safeguarding issue, and do we pursue it? Do we know what to do with it if we hear about, you know, all those sorts of things?
I think training has been looked at, actually. I've literally been asked about
And in fact, we
training.
have done.
And I know that that's on the cards again for early next year, because I've been approached. So once that's been done, we can then support yourselves in order to then support your constituents, really.
And whether it's, I mean, I know lots of people will do, but it's something that's compulsory, because I know that training, there can be different sessions put on, but I think when it's something that's this important in areas, it should be required that people update knowledge and train in the right way.
Yeah.
And then going on in terms of training from another side, whether the board's assured that staff in partner organisations only are completing required training, as I know in other boroughs, the uptake can be quite low and concerning in terms of safeguarding partners. So police, health services, officers, housing, what is the uptake in training in this area? Can we be assured it's the sufficient rate that it should be at? As it's something we should be keeping on top of as well.
The uptake of the training is very good. We do get very good attendance. What we really keep an eye on as well is making sure that that's the case across all sectors. And sometimes sometimes it's difficult, for example, for police officers who are out on the streets. It's very difficult to find time for them to come to multi-agency training. I mean, the police are very strict about officers going through safeguarding training, but that's not quite the same as actually having training alongside other agencies, so that you've got a multi-agency perspective. And so for some of the work, then, you know, we've been working with the police about how can we actually kind of facilitate that, how can we make the training available, you know, in the most kind of accessible ways for them. So we're always looking at what are the barriers to training, and we do a review each year. Where do we feel that we've actually got to kind of reach out to groups of staff, you know, across the board, that we feel should be participating more than they are. So it's something that we do an audit of.
But you're satisfied with the level that's...
Yes. Overall, the attendance is very good.
Any all that to close, but I think, any recommendations for anyone? It's just going to be close, but
Did you ask anything about the learning disabilities? Safeguarding.
I do think so.
Well, don't come through any check. No, I did, but it's fine. I think maybe I'll get the answer. Their training anyway. Is there any difference between the training for learning disabilities and normal residents? And safeguarding issues, or everything's the same?
So we tailor training to groups of staff that we are training, but also the training is tailored to specific issues and also specific groups or residents who might be subjected to harm or neglect. So you know, it isn't just the same training over and over again. It is quite special. and centre for people with learning disabilities, for those working with people with learning disabilities and people, and people who perhaps are unable to kind of speak in terms of saying what's happening to them in terms of kind of harm. We need to think about that in a different way and have different kinds of trainings of what you might look for. Than someone who was able to articulate what was happening to them. So, you know, there are differences.
And how often is that training?
If we just have an
Every year?
we have an annual training program with something, and there's a sort of basic level of training that everybody must do in terms of understanding safeguarding and what it's about, and then specialist training for specific groups. On top of that, I'm also making sure there's always a multi-agency perspective, because the real difficulties that happen when things go wrong is usually because agencies haven't worked well together, and that there've been communication problems. You know, somebody meant to tell somebody something and that didn't happen, and what have you. So the training ways actually bringing people together to look at what are the barriers of them working across the board is also really crucial.
Thank you. Thank you. Thank you very much. And it's an amazing report. I think in terms of the committee, we welcome looking at how we can show this report. Maybe as well as sending an email to councillors, but also in yearly training. Thank you.
Thank you.
Thank you.
Moving on to agenda item 6 about social care and budget proposals. The report accompanying appendices set out an update on the financial position for 2024-2025 and budget proposals, as well as responses to recommendations of the budget working group that will draft 2023-2024. This the big Director of Social Care and Jackie managing to present reports. Councillor Will Pascal, who is chairs the budget working group on this year.
Great, thank you, Chair. Yes, so obviously you will have in front of you the big report, which is the medium-term financial strategy, and that covers the whole strategy for the council. Now, we're only going to be talking about especially the adult social care element of that, but just to let you know, like all councils across the country, as you may know, there are certainly budgetary pressures. So we've got about 4 million budgetary shortfall for next year, 24 million for the following year, and the following year after that, a 42 million budget shortfall. As members of the committee may know, we are legally required to set a balanced and robust budget. That means the amount of money we bring in has to spend the exact money that goes out. We can't do what the government does and borrow and not have a balanced budget in that respect. So for adult social care for this coming financial year, we've had to make some budget reductions, but I think, as you will see, they are pretty good and all about efficiency. So frontline services aren't being cut. We are reevaluating in-house, which Viz will be able to explain a bit more on how we're going to do that. Now, there is still pressure on adult social care, of course, like children's services, as I said. They're the two biggest spends of the council because they're the very most important things we actually do at the local authority. But they're pretty, as I said, they're pretty robust in what we've got planned for the budget when full council considers that and scrutinises that in March next year. So I'll hand it. That's my introduction. I don't know if this wants to make any comments, but we can take questions from there.
Thank you, Councillor Randall. I just want to give you, I think it would be helpful to give you a strategic context about the adult social care as an organisation, also the budget and the risk, etc. Because if you look at our budget, so the gross budget is about 70 million and the net budget is about 40 million. And about 35% of our budget is an income from the health service. So although we have two different organisations, health service and the local authority, but if there is a budget changes in their organisation, will have an impact on us. I would say there are two types of impact. One is the direct impact and the other one is an indirect impact. So the direct impact is that we get about 28 million as a BCF. And also last year we got about 2.1 million as a discharge grant. So if they decide to give us less, then we'll have an impact on us. So that's straightforward illustration of the direct impact. And the indirect impact is that if there is a delay in elective admissions, so people having their hip operation or knee operation not done in time, when they come to us, they're going to need more care. So therefore, we will have an increase in spend on care and placements, etc. So that we already see an increase in complexities because there wasn't a timely intervention. However, we are getting quite a lot of one-off grant from the government, and that is helping us to come in budget. So there's a lot of factors there which we need to be mindful. And also now one of the risks is that the North West London ICB, I think they will have to find some savings, or should we call reduced spend, so that also will have an impact. So I just want to give that as a context so that it wasn't there in the report, so I just want to say that.
Chair, like follow that. Just to say, first of all, I need to declare that I'm a governor of Chell West Hospital. I mean, that's obviously if I'm making a remark about the NHS, you need to know that. Secondly, a couple of quick points. You've had Jackie has done some guidance for the committee, which has been circulated. And I thank Jackie for the work that you put into that. And I wanted to just identify a couple of points there where the report from last year's budget working group recommendations followed up a report from by Liz Taylor about the implementation. Two areas. One was to do with the benchmark and the financial outcomes, particularly with regard to investing and reducing the need for service demand, and how that goes forward into the next year. And secondly, improving the management of risk, which Liz referred to. And there's a slight ambiguity on timing and content with regard to the NHS. And he's referred to the current reviews by the ICB. I don't think that there's always an understanding looking from the, I'm not on the ICB, but I get the papers there. And some practitioners there understand that if you reduce the spending on intermediary interventions, that you actually increase the likelihood those cases are going to become acute or severe. It's pretty much the same thing you're talking about. So early interventions mean better outcomes in hospitals, less care afterwards. If you go the other way and you actually don't fund so much from the NHS and don't do things early within the NHS, that pushes an intermediate demand up the triangle of need, and it then becomes disproportionately more expensive, either for the NHS or ourselves or both. So there is a bit of a learning exercise going on, and not all the practitioners in the NHS that I've seen agree with each other on this, and it will also domains of subject. So the second point I want to make was with regard to procedural arrangement. It's particularly important I'm sitting here as the budget working group, which your chair, I think Gerald is the nominee on that, in that case. Particularly important that this committee is so minded to regard something as important in the budget area, make it not just minuted within your group, but make it a recommendation from this group to the budget working group. And then it will follow into a collation exercise with other committees work to OSC and then through to leadership team and to the council. And that's the pathway by which you get most recognition of items that have been identified by the subject area specialists, which you, in case of social care and the other management service. So those are the 2 points.
Just I think as already been stated, but I know we've got the full budget head, but just in terms of focus on ASC. I don't know if anyone wants to start this off on Appendix A. Garrett,
And you say,
that is page 207 for the budget pressure and growth. On the
I'm sorry, I want to comment on the planning to be.
yeah, I just. I mean, one question I had was just how is the modelling of budget pressures done? Yeah, interesting.
Right, okay.
To understand.
I can answer that. So, the modelling, we've been doing various savings for some time, and we learned all the way in the past. I think that the first thing is about the budget, about the adult social care budget is a demand led, and it's also a volatile in terms of demand, and also so many various factors. Like I said about the health service, if we don't get the funding that we want to get it, then that'll have an impact on the budget. And also some incidents like COVID happened, and that's still we've seen the impact on that. So what we've done in the modelling is that we went through the budget line by line, and the spend versus the budget in the last few years, so we could see there are any efficiency. But one of the key themes when we decided in the council round is that no cuts to services, only efficiencies. And also our theme is also about empowering people, less reliance on long-term care, and also less intrusive care. So in a nutshell, that's all about promoting independence and the right care at the right time, so that no waiting list, providing services for those people who need care in the right place at the right time. So that means, hospital teams are in the right place, the discharges taking place without any delay and on that front, and also using the digital, etc., to provide the right service. So that's the way we modeled our budget, and also look at the savings proposals as well. And some of the savings we've done in the past, we thought we could do more based on the experience what we had in the last 2 years from promoting independence. I talked all about promoting independence because I think, like Councillor Pascal said earlier, it's all about you're providing the right care at the right time. If you don't, then it becomes a high cost care provision, so that we want to be able to provide in the right place.
And in terms of just reliance on central government grants, how does this affect our budget planning, particularly as we not?
Yeah, I think
particularly clear on understanding when we will know about these and moving forwards over the years.
Yeah, it is difficult because most of the grant coming to us are one-off grants. They are not sort of revenue forever. So, for example, the BCF is sort of reviewed every 2 years. So you get about 20 million through the ICB, and 8 million directly from the government as an IBCF. That was discussed at the last, I think, the spring statement, and it's again confirmed in the autumn statement. So we will get that for 2 years. And also we get various grants like market sustainability improvement grant. We get about 2.1 million, and also workforce grant about 1 million. So those all in there, we're factoring those into the budget for the next year. So we know that that's confirmed. So we're very clear this year and next year we're okay. However, that, like I said, the discharge grant is about 2.1 million, and the 1 million has to come via the ICB. Our worry is that if they have to find savings, will they give us the money what we need, and that helps us with the hospital discharges, etc.
And what if they can't, what position will be in terms of risk?
I think that we have some, the first thing is that we are working very closely with them because like they have a lot of interest in this because every day to delay a patient will cost a lot of money for them. And also it's about the outcome for service users and residents or patients. So therefore, we have managed to get what we needed for this year. And we think we will get what we needed for next year. I can't sort of sit here and sort of guarantee you that it's going to happen in 25, 26. I don't know. But for this year is fine, and for next year is fine.
We're happy with any other questions on Appendix A. Move on to.
Looking at Appendix B. Initial on layout stuff. So that first section though, where we say we're making proposed reduction of 550. Is that split then between, there's various headings here, continuation, direct for digital. Is that split between those headings? And is there an indication of each heading, how much it contributes to the 550?
Correct. Yes. So actually the layout is making it a bit complicated, but the continuation of prevention initiative is the theme. And to get the money, the vehicle is one of them is the direct payment, and the digital, and also providing the right accommodation for.
But is there any indication for each of those?
We have some figures, but we haven't because we would like to have some flexibility, but we have full working behind that 550 promoting independence.
So we looked at the RBKC is home.
Yeah.
Clearly, what you're saying in the second paragraph is that this is a build on 23-24.
Yeah.
So if we don't get 23-24 saving doesn't happen, it has an impact on 24-25. Are we confident that 23-24 is happening? So 24-25 will.
Yeah. So these are the answer. Yes, we are, and we aim to get we aim to meet the target for 23-24. Altogether, between 1.5 million savings, we have to deliver the whole list of savings, and these are cases like, for example, those we've placed for various reasons outside of RBKC, but their family is here, and of course they want to come home to live near their parents if they're younger people, or older people with their children, or the person with the friends and families. That is our aim, so it's a good outcome. But I think we're working towards bringing more people as possible. Of course, they will have to like it, and it makes sense for them to come back to RBKC. But in the response, I think we will deliver those savings. Yes.
I guess the general point is it's difficult for us to know or be confident that these savings are going to happen when we don't know how they're going to happen. And so, for example, it's obvious, isn't it, that there's been a need for 2% staff cutting across the board.
Yeah.
Everyone's put in 2%, but this service will review its spend on staffing. And how do we, as a scrutiny, as a statement, know that that's going to? I mean, it's a nice statement, but if we want to feel confident in this happening, I guess we need a bit more confidence that these headlines will happen.
So to reassure you, so what we do, every single month we look at this, we have what we call a saving tracker meeting with the director of the service, where we track all these savings and see if they've been achieved.
So you mentioned that in 24, when a knock-on effect in 24/5, if it doesn't happen, well, we can reassure you that we've already achieved or will achieve all the savings that we've identified for 23/24. Planning is already going ahead, or there are savings that have been identified for 24/5. So we need to start now, plan it so that those savings can be achieved, and we will monitor that every single month via meeting the directors, heads of service, and monitoring it through our savings tracker.
So basically, we have a very, Mark is the head of finance, so we, everything we do, we have a very good working relationship with the finance team, because it is good to have the challenge from the finance. So when we put forward a Mark, so Mark's team will say, that won't work because the figure doesn't add up, or in the past we haven't done it. So the meeting I'm referring is that we got this MTFS monthly tracker meeting on a monthly basis we had. With the two levels, one is with the director's level and the other one with the head of service level, to make sure that we just follow that. And that is an impact. I chair that the meeting to make sure that if we don't do it, then we come up with a plan to make sure it is achieved through another means.
Just going on what RVKC is home, which is obviously a transformative program.
Yeah.
Which with a saving of 400k, which is a substantial amount. Do we have any examples of when we've had transformative programs in ASD that have achieved this amount of savings? Just so we can have, I know we can't measure it here, we're hearing what you say, just that there's.
Yeah, I think Mark's just showed me the papers are better.
Examples of
but I just, on a social work point of view, I can give you an example that, we place people with learning disabilities outside of RVKC, and their parents or family lives there, and they've been waiting for daughter to come back home. So we managed to find supported living, etc., in the borough so that they can move in. And in fact, most of the time when we place people outside a borough, we must have done in a rush, someone discharged from hospital, there's no vacancies, and we place them there. So now this is a planned approach. We work with the families and with the provider, therefore we managed to find those savings.
So following on from what Liz is saying, is that over the years, since 2017, we made £4.5 million worth of savings by promoting independence. That's looking at people's care packages, reviewing them, bringing them from out of borough in borough. So we've got a proven track record for that. The savings that we put forward, we can achieve. And we achieve that by working with the families and the service collectively, making sure that that's achieved.
Actually, I have a very similar question to Giles, unfortunately.
I'm just very interested in the fact that all the services that we've outsourced out of Kensington and Chelsea, is there a contract management procedure in place so that we know that we're getting value for money, to see how that we're monitoring and evaluating our services so that we are confident in doing so the following year and the following year? And I know it's about saving money and making the best service, but I want our clients also to get the best value for money. Yeah. Is there any sort of procedures like that in place for us to check?
Yeah. So we have every contract, every placement we make in the borough, outside the borough, there is contractual. There's three things there. One is every person placed in or outside the borough, we do a annual review on a yearly basis. So when we place someone, we do a 4 to 6 weeks review to make sure the person is settled or receiving care package, working or not. Then we must do a review within a year. So the annual review. And our annual review is about 95%, including the reviews. So that whether they are in or outside, even if you place someone in, I don't know, Yorkshire or somewhere, social workers will go out and do the review. And so that's one way of doing a review, checking everything is in order. The second one is that we have a contract management team, and the contract management team review the contract with the provider And the third one is the quality assurance service, which is part of the visa service. And they also work very closely with the provider, not just with the provider, they also monitor the CQC rating, because the CQC monitors and inspect and publish. So there's 3 safeguarding arrangements in place to make sure they are okay.
Very interesting. So can we get some testimonies? Do we get testimonies from the client themselves, apart from just the CC report, visit and report and written report? Do we get any form of feedback from the clients themselves?
Yes.
Okay.
Yes, definitely, yes, we do get, and that's part of the reviews and the social work reviews.
Thank you.
Part of the contract anyway, there will be key performance indicators that the provider has to adhere to, and then managed, I think, on a monthly basis.
Yeah, it was just a quick question about the RBKC's home heading. I understand the drive to kind of bring people closer to home, to relocate them. But in what way would that be saving money? Why would that be where are we repatriating it from? Why would they be in costly settings anyway?
So even, for example, that when the COVID times, we discharged people in a not the hasty way, but really with the speed because of the bed space, etc. So we place people in Brent, not far from here. The providers would have asked for a lot of money, and it may be difficult for the families even to travel to Brent, and they would rather have someone here. And we can find a place cheaper than what we're paying in Brent, because it's not a block contract, it's a spot purchase. We just find anywhere in 2020, really tiny, and 21, placed many people outside because there wasn't many beds in the borough, so we had to place people outside. But it's not. It has to be agreed by it has to be a part of the social work review, and the family and the president has to agree to that move. So the person will make a decision whether it's the right decision.
I'm just trying to understand why it would save money. Why?
Because if you don't place in a block bed, it is most of the time you're paying. It's expensive.
And that's where this is a little difficult to understand and ask pinpoint questions, because that is a paragraph.
Yeah.
There's, as you said, there's heaps behind that paragraph that we're not seeing. So I'm trying to gauge that. Is that realistic? Is it going to happen? Have we got the workforce to make it happen?
Yeah.
Were the beds within the borough to make it happen? Now, no doubt you've done all that work, but I think, Chair, it's difficult for us to ask
I've got
good questions on bold statements.
I'm just trying to understand why they would be in these costly out of area placements anyway, if we have the resources and the bed space to bring them closer to their homes and their communities, and it's cheaper. So why are we sending them far away somewhere more expensive if we have these places closer to home to bring them into?
Yeah.
Or are we needing additional resources for that?
Yeah, because you see the beds are capacity is changing every day. When someone is discharged from the hospital, has to be discharged, there is no beds here. So you have to find the bed somewhere nearby. So
and then as soon as it becomes available closer, you bring.
Then you can bring them back.
We'd be doing that anyway, no?
That's one thing. The other way of doing it is, you will see there are other savings, that we managed to get about 5 to 10 nominations, housing, general needs housing nominations this year. 24-25 means there are people in supported living. They could have their own tenancy. I'm talking about people with learning disabilities mainly, and people with mental health problems. So they are in a supported living, very expensive, and slightly high level of care than normal housing with the care packages. So these, they will we will get the housing benefit and we will provide the care through the care packages. It's definitely much cheaper than someone lives in a supported living will cost us about £400 to £1,300. When you have someone living in their own flat with the wraparound support, it's cheaper.
So that brings me on to the next question that I had, just because it just sends chills down my spine when I see kind of saving and cost cutting framed as giving people back their independence and you know, supporting people to live more independently and have better outcomes for their aspirations. That all sounds fantastic. Everyone wants to be independent, but if someone requires a service to live safely and that additional support to function safely, actually that's what independence is, and that's what freedom is, to live a full life, to have the support. So I always just immediately get really suspicious if I see cost cutting mechanisms as we're trying to give people back their independence. Actually, we should be trying to reduce support for everyone the moment they don't need it anymore. But the only way to do that is if suddenly people's needs diminished and therefore the services they required suddenly diminished. But what we're hearing, you know, at every meeting, one after the other from all these different representatives that come to speak to us, is that needs across the board are going up rather than down. So I'm just not sure how we're trying to suggest that we can afford to withdraw services, because actually that's just going to cost more in the long run.
I think, you know, it's a very good question, and we must clarify that. I can assure you, we have been doing this, promoting independence in the last 5 years. We haven't received a single complaint. But this is about not cutting. It's about working with the service user, resident and their families to find the right level of care. It may not be reducing the care. It may be changing their accommodation will help, will save a lot of money. And they wanted an independent life. I mean, if you speak to the learning disabilities, I'm not talking about everyone. There are some people who could live in the communities, and the families are lobbying for housing for their son or daughter. And I can give you so many examples. And we managed to get this now. Therefore, they don't need to stay or live in a supported living with other people, and also their quality of life, and they don't want to share facilities. So that is going to help in terms of this providing an accommodation. So that's one way of finding things.
Okay. So that would suggest then that there are people who are inappropriately placed, that they're in having levels of support that they just don't need.
That they improve because they needed the support, but they no longer needed the level of support, and they are ready to move on. You think if we look at about the mental health services?
Sorry, the learning disability.
No, in learning disabilities,
that doesn't improve.
No, it doesn't. Medically, they don't improve, but they can improve with the daily living activities, learning new skills, etc. So they will be able to live more. I'm not saying suddenly they don't need anything, but they will need care, but in a different setting, with the level of care may be different. And the other example is that reablement also part of this setting. So reablement in RBKC is about over 80% of people going through the reablement service. They no longer requires the long-term care packages. Our reablement service is quite good, and that's about 80%. So that is also, so this saving we set here is not all of them are going to come from those placements coming back to RBKC. It's the various sources in terms of re-enrollment is a very successful, isn't it?
It's increasing the number of people that go through the re-enrollment. So they receive a high level of care for a short period of time. And from that, 80% do not go on to receive long-term care. So initially, it costs us a lot of money, but long-term, we're saving money.
Sorry, it's just that I only, in my day job, I only see the disasters that happen when this kind of care is withdrawn.
Yeah, but I think we would like to know if there is an issue, something withdrawn, because any care provision, whether it's an increase or decrease, it has to be as a result of a social work review. We will not and we cannot simply cut services, and we don't do that. But if anything comes up, then I'll be very happy to take that on and deal with that.
I've just got a question for you on direct payments, which again, there's not a huge amount of information on, but in terms of what the existing performance of direct payments is and how all the uptake increase that we can be.
Yeah, I think our direct payments is we set a target for 36%. And the direct payments is not for everyone, because there's some family. Direct payments is basically you give them cash to buy their care.
Yeah.
And it suits some people, but not everyone, because it involves the patients or the service users take them as an employer. So it is a lot of hassle, can be a hassle, but it again gives choice and control. They get the care, they get the money to buy the care from their own community, cultural needs, etc. They can do that. And that is a challenge, but we want that to be working, because that's the way forward to provide choice and control on the people. But we're doing, we are increasing the number of people working on to get the direct payment. The important news in RBKC, we have also set up a team 6 months ago. It's a direct payments team. It's a dedicated direct payments team, and their job is to work with families and whole service, provide all the support they need, bring them on direct payments. And that, I think, is the way forward in social care, rather than providing agency care.
No, I appreciate that. It's more just in order for it to us to be encouraged that.
There's actually a question about that. So you're saying it's 36% now, did you say? What would you hope it to be at the end of the financial year 24-25?
I think, I said 36% is the target. I think we are at 20.
Okay, so by the end of 24-25, you want it to be?
We want that to be.
And it's about 20.
Yeah, at the moment it's 20. The target is 30%.
Target is 37.
He's got the
Sorry,
figure.
the target is 35, but we're achieving at the moment 30%.
Yeah, so we need an increase.
Yeah, we need to. And it would be good to do even higher, be ambitious.
And you're confident, so you've described that in order to make this work,
yeah,
you need to put in other resources.
Yeah.
And do they outweigh, the obvious question is, if it's going to cost more to do it, are we still going to save money? Because one does get a fair amount of casework, people who've taken on direct payments and get into an awful model.
Yeah.
Now, I appreciate the technology is improving in that area, so that will help that. But are we confident that the increase in cost to do this is going to be outweighed by the increase in uptake and the savings?
Yes. Yes, because the team we set up. So what used to happen is that the social workers in different teams, they were doing the direct payments work and carefully, and they're not really becoming expert in direct payments, but they were doing assessment and direct payments work. What we've done we invested in one team manager. That's an additional investment, we could say, investors say, and the social and the staff, 3 staff, they are from different teams. So so it's about transform a new set up a new team from the existing resources, but change the process to make it more effective, but additional resources of the team manager.
So of the 550,
yeah,
what figure are you putting against direct payments?
I think I think it's about 175. It's less than 200 paid.
It sounds like setting up a new team is in itself expensive.
One team manager. Yeah.
When you talk about the team, I assume.
No. But they are from different teams. The staff brought in and changed the process to make it work. So the additional staffing is only a team manager. So that's an investor centric.
Yes. 1 second, I won't take much of your time. This is just something that's been really bothering me. I'd like to ask you, based on your experience, how do you know what care package suits what residents based on how do you choose? Because you have a client saying, look, I've been paying my dues, I've been paying everything, but they're only allowed to have the bare minimum care package. And then you'll have another person that will get everything. How do you differentiate? How do you assess them? How do you keep them informed of the care packages that they're allowed to have?
My background in social work, so I was a social worker, so I used to do the assessments, etc. It is not an easy job for social workers to do an assessment. You're walking into someone's house and they've never been there. It's the first time they meet and build the rapport and do the assessment, etc. So I'm not saying they get it right all the time, but what they will do is they will, they're trained to ask the right question, like the doctors or in a different profession. They are trained to ask the right question and understand. Basically, it's a needs assessment. So they need to ask what they can do, what they can't do, and then help them to build care arrangements that's within the professional talk as a care package, and give them choice. What do you think you manage? In the morning, do you need care, or evening, do you need care, or whether someone who is need a lot of care, can they cope with the care package, or they need to go into a different accommodation? So it is a skilled.
That's how it should be done, but I've often been told that they've been their minimum.
But I can't.
So this is, I know it's not your job. I just wanted to know. I'm very intrigued to see why someone would, walk all their life, pay their dues, and then they're just getting the bare minimum in a care package, and another person will be getting also. I just wanted to know if there's a difference.
No,
in how you assess.
There shouldn't be.
Okay.
The care is based on the need.
Okay.
Based. Yeah.
Care is based on
the need.
Yeah.
Yes. Yeah. But if there are any cases, then
yes, thank you.
Anyone want to make any recommendations to the working group?
Could I comment on what
You
you heard?
Absolutely. Well,
It seemed that the right care, right place, right time, but particularly getting it early, that seemed to be a focus. Re-enablement, done correctly, not only seem to improve patients, so save money. And I think the Gerard made is that making some of this data more transparent, making it more useful for scrutiny.
Yeah.
And I think also the direct payments team be useful to get more evidence of progress that's been made.
Yeah.
First to answer stack out to make it. It's your committee. Public life, those ones. I heard you speak about.
I would agree with it.
And I think the first point you made though, Will, is not in itself a recommendation on the budget, is it?
Well, I think that the recommendation would be to focus on the further on achieving potential, getting the right care at the right time and making sure that happens. So it's evidence, further evidence that you can do. But I think there was some skepticism. I think probably I heard Mona saying that she only hears the disaster. I think it's the disasters where it doesn't happen. That's okay. We're doing a fantastic job to do those things they work. If this is the aim, the recommendation is to give better evidence, more evidence, and particularly over time, because you're trying to work the percentage up from on the direct payments from 20 to 30 to 37. It's the direction of travel. And can you achieve, can you and do you achieve that? And that continues with the direction of travel.
Yes. So building that, part of maybe a recommendation is we tend only to get, when we get reports, we only get good news. So can we also have examples of where savings haven't happened, why they didn't happen, etc. Because you look at these and they're great, you know, one can't, but they're just wonderful. And I'm always, when I see a report that's full of wonderment, one has to think there must be something else to it.
But like I said, if we don't get the health funding, we won't be able, it will be a high risk. And that's what I believe is very high risk.
But also conversely, having a kind of gold standard benchmark versus where things have gone really well. So those examples where, you know, people have been enabled to live more independently and services have been withdrawn successfully, and having, you know, examples of that would be also be great.
Yeah.
When I check, I guess.
Yeah.
And also some of the transformative AFC examples would produce that type of budget. So don't quite
if I may, that's probably not best for a budget paper because you probably won't see one for another year, and you may want to see one before that. But we're happy to provide if you want to do a specific things on transformation of the service.
Yeah.
Which we can get back to you on that. But I'm just saying, just caveating that, because if you wait, then some members of this committee may need will be, other people may replace and make it other cases and stuff. So just raising that as a, if you do want to scrutinise that, then that's up to you, of course. But just to keep that in mind.
Can I add one more? Is that it's part of the same thing. That I don't know how you feel about this, but I think a recommendation could be that the service, which is doing what it's doing, would be encouraged to have further conversations with the NHS and the ICB, or whatever part of the ICB, because it's a massive organisation, to actually try to get them to understand the interaction between giving early intervention and late intervention, because of so in other words, consequences of them starting the early intervention process with resources. That if there's absolutely no point in the ICB saving money in their area, it's going to mean more expenditure in our area. It make it very impossible for us to do what we're doing, but at the same time, just make it more expensive.
We tried to, and I don't give me chair if you scrutinise the ICBs as well, I don't know, but the ICB has a budget of 6 billion. And we are constantly scrutinising them as well for our own fair share and what we believe our own fair share is. So we can only do that so far. I can do that so far. Politically, Burning the team can only do that so far as well. But it's also what you're picking up there, Will, that we need kind of overall to ensure that we are getting the right services and the right budgets from the ICB to our residents in a way that is appropriate. Can I tell you the ICB is doing that yet? I don't know, if I'm honest. But we then perhaps a mechanism to do that maybe worthwhile. But as I said, we do that in our meetings anyway, but and try to put the message across, as you say, as it is. But whether that's
I mean, what I pick up from discussions that I heard is that this is still a work in progress. Is them understanding the consequences of cause and effect, and the relationship of putting money into intermediary need, if you like, and acute need. Between the relationship between those two is not fully worked through yet. And it's a multi-agency thing and it's a multifactorial thing.
Yeah.
But I personally think whether this committee's got the appetite to make a recommendation to encourage that engagement, it's up to you guys. But I certainly think it has enormous budgetary consequences.
I think it makes sense to try and understand that relationship a bit better. That could be a recommendation, to try and understand it, because I think it could work both ways, because the NHS, you know, could also argue, you know, if there are shortfalls in investment from social care and people aren't getting the social care that they require, that then will drive up healthcare need, and then there will be healthcare spending that they have to kind of compensate for. So they could probably say it works in a way, I don't know.
And before
It would be worth understanding that relationship better.
Yeah. It sounds
Well, from me, we're looking forward. The thing which I might have missed in what you were saying is just, and it may be a whole different topic, but do we have for this particular section of adult social care, are we in surplus, or is there a gap in current year?
We've got a break-even budget at the moment, but it's getting very, very tight.
So you're currently tracking
Yes.
the numbers,
Yes.
and is that typically the case for this area that we're working on? That you can keep it that amount of control?
So I think,
And it's a much bigger topic, but we've got a lot of different headwinds.
so apart from Westminster and Berkeley KC, all other local authorities within adult social care are overspending. So we're both of us are breaking even. And that's because of the hard work the service does in mitigating any cost pressures. Also, lobbying health, we get promoted, you know, economies across the world. So it is, I have to stress, it's getting ever more difficult.
It's very challenging to get the ICB to commit to the funding. But then again, we also seen, like I said, we've seen an increase in complexity of patients and services coming to us for various reasons. Therefore, the cost goes up. So it is very challenging, like Mark said, that we know it's local authorities are struggling. But what I would say is that we have been in budget, but it's a very, like, we have every month we have this MTFS budget meetings to make sure it's being monitored. At the same time, we also have a performance meeting once a month, which is to make sure that reviews are done 95% quality assurance aspect of the work. So it's about it's very challenging.
And I was going to say, I take assurance from that, because if your budgeting was actually meaning that you'd underspent by 2.5 million, then the budgeting is not right, or you're not providing all the service that need the money. So the fact you're tracking on target, getting a monthly look at it is assuring.
Is everyone happy with the recommendations that we've discussed on the committee? Yeah. And we've got thank you. Moving on to agenda item 7, work programme report. The report gives an update on the work programme and scrutiny activities set out. The reports received in the municipal year. The committee has been agreed with the report as results.
Yeah, let's have the meeting for the next meeting. It looks like a heavy meeting for the next one.
I think it's a very heavy.
Which one?
Just the best one. I feel when you see a meeting like that is we don't spend any time on anything properly.
That's a perfect. Wow, okay.
Yeah.
Anything we can do about that?
Well, yeah, I think capacity check, I mean, so my suggestion is that.
Move on, move. Yeah.
Well.
To move to down
So you can decide if you can take it.
Yeah. Otherwise, I think we would do that.
Yeah.
Yeah. Is it worth us exploring what the most effective ones to bring this data as to agree those a bit?
I think it's about 5 minutes actually. I think.
Yeah, to all time exactly. Yeah. In terms of taking that conversation, we can see when the time units would be best.
Yeah.
And then we can agree which two to take over.
Yeah.
And circulate that with the committee.
Yeah, that's the best way.
So we can move to, but we're gonna see what times work best.
Can I just say there's nothing unless I'm about to show myself up and it's there. Anything on here on the suicide prevention strategy?
Yeah, what is the update with that would be this separate group.
Yeah, well, so we're still committed to delivering that as a working group, but obviously we're mindful of our members' commitment to capacity at the moment. So I think realistically we're better to start that in the new year.
Yeah.
Because 3 of the members have also considered using new jobs as well. So I think darling up with
that. I knew that's why. Yeah, that was exactly useful too. I think because our JOS meetings will probably it's towards the end of
yeah, but also by being on the JOS as well, I think it'll be we have a full view about suicide prevention.
Yeah.
Basically.
Yeah. Okay, if we're happy with the rules, push that. Yeah. And I think I mean it would be mad.
Yes, I'm calling, I think that will be anyway.
Just one of the really quick bit of business, which is at the last meeting, when the committee looked at home care recommissioning, it was mentioned that my home care KVC has been re-inspected.
Yes.
So the re-inspection has been published today.
Yes.
And the rating requires improvements. So I'll circulate all to you in today, it will be today. But what I suggest today. Tomorrow. What I suggest is we've organised a briefing with Gareth and the integrated commissioning team.
Yeah.
Yeah. So you can literally be to do that.
What I mean, going forward as a committee, is there anything we can work around that?
I mean, it's completely up to you. I mean, you could bring a report to committee, but I think probably thing to do is to have a look at it, digest it, discuss with the officers what the operational implications are, and then go from that.
Everyone happy to do that, and then we can make a decision what's the right going forward. Thank you, James, for that. And there's no other urgent items. That concludes this meeting of committee. Thank you, everyone, for your time.
Thank you, Lucy.
Yeah,